kidneys. That's when the blood pump from the heart. It's an average. I won't worry about the branches. I know they're in there on the model. I'm gonna show you the diagram for that, but don't worry about it. Worry about the nephron, the tubules, when it comes to models. Yeah. As I promised, branches of the renal artery, how it becomes arterial artery, interlobar, interlobular artery. I'm not gonna go through that, so make it easier for you. Although we have them on the model, but I said that's kind of like a deep anatomy for you. Okay. Worry about structure of nephron. Know the glomerulus. Know the Bowman's capsule. Know the proximal convoluted tubule, loop of Henle, distal. You know, those are the ones I'm gonna ask you on the models. But branches of the renal, don't worry about it. Okay, even for theory. Nerve supply, we talked about how sympathetic can affect you. Okay, remember we have an artery entering the glomerulus called afferent with the A, one coming out called efferent with the E. So when we get the blood to the inside, if I constrict that afferent, which is going in, I'm gonna minimize the filtration, correct?
Yes.
Yeah, well, less blood going in because you're constricting it. And that happens in sympathetic nervous system stimulation, all right? And vice versa in parasympathetic. And don't forget also to talk about sphincters. So in sympathetic nervous system, we're gonna store more urine. You're gonna have less urination. You're gonna have less voiding when you're stressed out, correct? Yeah. So what happened? If I ask you what happened, how this happened, you tell me. Bladder wall relax, sphincter constrict, so you store urine. And what happened to the afferent? What we said? Afferent, the one going in, what happened to it in sympathetic? Constrict, exactly. So put all those together, and that's what happened in sympathetic nervous system stimulation. Now let's go to parasympathetic.
Wait,
yes.
So the bladder relaxes and the sphincter constricts.
Constrict, so you store urine. Yeah. You don't want anything to come out, of course. In para, let's talk about para. More filtration. So what happened to the afferent diameter?
Gets bigger.
Bigger, it dilates. So more blood going to the glomerulus, more filtration to the Bowman's capsule. Now let's go to the bladder. What happened to the sphincter? Relaxes. What happened to the wall, which is made of small muscle?
It contracts.
Contracts. You see, I'm doing the opposite, and the urine comes out. All right, so I explained to you both sympathetic and para and what happened. This is the one, it's on also the model. Make sure, guys, to know all those tiny parts. And I saw them on the big kidney model. You can see the renal corpuscle, which made of glomerulus and Bowman's capsule. You see that C? That's a Bowman's capsule. So blood makes urine. So the blood goes into the afferent, so entering here, the glomerulus, and start filtration, and now retained where in the C structure, which is Bowman's capsule. Then you deliver it in the proximal convoluted tubule, loop of Henle, which is U-shaped. It has descending limb and ascending limb, and distal convoluted tubule connecting to the collecting duct, which opens where? In the papillary duct. Look at the papillary duct here. We have tiny papillary ducts, and now this opens into minor calyx, and from minor into major, and you saw those. And hopefully today I'll let you dissect the kidney. Yeah, we can leave it until the end. Yeah. It's not gonna take time, you can do the kidney. I'm also thinking of next week, Tuesday, we can dissect the fetal pig. Yeah. Next week, make sure we're gonna dissect the fetal pig. We're gonna finish it in one session. Better. So, and then if you wanna keep it, put it in Ziploc bag, put it in the fridge, take it out whenever you wanna review it. There will be questions on male and female pig. So alternate, if you have a male, you know, go and see the dissection of the female. The only difference is the reproductive system. We're gonna see the ovaries, uterine tubes, and in male you're gonna see the vas difference. Also dissect the testes. Know all layers that surrounding it, and some of the glands that produce semen, such as epididymis. So we're gonna introduce you to many structures. And you want dissected fetal pig? Oh, here in at
No,
National?
it's outside.
Oh, outside. You did it also
In high school.
in high school? Oh, so you went through all, oh, okay, that's good. Can make a review now. So here is what we said. Renal corpuscle consists of what? Glomerulus and bone stems. It's repetition, you see? Mhm. Now, we're gonna show you the diagram, I think, because diagram can make it easier for you. Yeah. Efferent, I talked about that. There are some mesangial cells. They have contractile ability. You see, they can squeeze themselves and help, you know, with the glomerular filtration. I want to show you also, the same thing here. Filtrate, oops, that's the one here. Here, we're gonna magnify it so you see all cells. We know Bowman's capsule lined by squamous epithelium. And we know also the capillaries having squamous. Yeah. You don't need more than squamous. But you can see surrounding them are cells with finger-like projections. You can see them in yellow color and the nucleus, you can see it here. But look at those finger-like projections, we call them what? Pedicels. Pedicels, yes. All of those, we call them podocytes, okay? So those actually are very important because we need to have openings in between the pedicels, correct? When you have finger-like projections like this, you have openings in between. So those, we call them slits. Yeah, the openings are slits. Slits means opening. So filtration slits are necessary here because all the filtrate gonna go through it. See? You wanna filter blood now, making a filtrate which gonna become your urine. So it has to pass through what? Those filtration slits. You see the openings in between the pedicels? Yeah, we're just gonna have a name for them called filtration slits. Spaces, slits. Now all the filtrate gonna go through those slits and end up where? Bowman's capsule. Make sense? And then you deliver it to the proximal convoluted tubule, which lined by what kind of epithelium you're seeing? What's this, guys, from part one? Cuboidal. Mm-hmm. So you can see the cuboidal epithelium. All right? And then you deliver it, of course, go back to the structure of nephron. Proximal convoluted tubule, to the loop of Henle, to the distal convoluted tubule, to where? After that, collecting duct, and then to minor calyx, after papillary duct, of course, and so on. Now you can see afferent. Here is the afferent arteriole, and here is the efferent, out, in and out. So when the blood delivered to your kidneys through those afferent, it enter here, circulate, and comes out. Circulate and comes out. While circulating, there is a pressure, correct, in the capillaries. So that will aid in the filtration process. Without that pressure, what's gonna happen? I'm not gonna have filtration. And that's the proof if someone is in shock. What happened in shock with the blood pressure, guys?
Decreases.
It decreases, correct? You check the blood pressure barely. Maybe it's 70 over 50, for example. We know he's in shock and I have to do something, correct? So, what's the sign I can see on the patient also to prove he's in shock? What happened to the urine? Decrease, oliguria. That's why when they come to the ER, you ask for a catheter, urine catheter. Quickly, give me urine catheter. And put KY gel on the tip, inserted in the urethra. Because we know the urine will be dropped, and that's gonna make retaining of urine, and that can cause infection. So I wanna function that and put the catheter and get the urine out, collecting in a bag. You see? So I want you to relate what you're doing in clinical and why you're doing this, because the urine decreased in shock. Okay? So in shock situation, and why, if I ask you why the urine decreased, what happened here to the afferent? Shock is sympathetic, correct? Constrict. So less urine will be formed. Shock is sympathetic nervous system stimulation, exactly. That's fight or flight situation. Okay, so this is exactly what happened. Again, I'm gonna repeat. We have those podocytes. They have pedicels. And in between, there are filtration slits. See the spaces in between those finger-like projections. Why? Because we want the filtrate to pass through them, to end up where? In the capsule, very good, in the Bowman's capsule, then to deliver it all the way here. And without that pressure inside the capillary, it's not gonna happen. And we get example on shock. Any question up to
Where's
here?
the Bowman's capsule in this
Here.
diagram?
That's the Bowman's capsule.
Oh, okay.
And all of those cells are squamous, which you can see them also at the edge, see? So those squamous, just flat cells. Flat cells.
What
yeah.
is the macula densa?
Okay, the macula densa, this one actually has cells. Those actually, the one I just mentioned, if you remember, I just mentioned them, show you, mesangial cells. Yeah, those have contractile abilities in the macula densa, where it can actually affect the diameter of what? Afferent arteriole. So those the one kind of like give that push to the wall and constrict it or dilate it. So mesangial cells in the macula densa are very important, and also they found them like part of the immune system because they can clean up any debris that lies in this area and affect the diameter. Mesangial cells can help in cleaning up the mess or debris that end up in that critical area, because diameter is very critical here with the amount of blood passing. So you see, so mesangial cells in the macula densa are very important, and it is part, of course, of the juxtaglomerular cells, all right? Juxtaglomerular cells or system. So So this actually produce renin, because you may wonder where renin produced from. We said the kidneys. So it's from certain cells called juxta. So you see that's the J, glomerular. And C4 cells. Those are the ones that produce renin for you to control your blood pressure. Remember, renin convert angiotensinogen into angiotensin 1. We talked about it before, and I said, review the RAS system. Gonna come in every chapter, in cardiovascular, in the kidney, renal, and so on. All right, any question up to here with the mesangial cells? See them here? Okay, so let's move on. Yeah, podocytes, pedicels, we talked about that, filtration slits. Yeah, if you understood that diagram, you could. Yeah. Now, this is very important. I will repeat, this diagram is very important. Why? Because it takes you like a 3Ds and how the filtration occurs. So here is what we found. We found, that's the section they took it from. We're just gonna do a section in that area. Yeah. Any of those areas, just make a cut section and see it from inside to the outside. All right? So we want to make a cut section in any area. I know they took it from here, but you can take it from any area. And we want to see the layers from inside to the outside until we reach what? The podocytes. Those podocytes. So from inside to outside. And we know the filtration passes through those filtration slits to end up where? Bowman's capsule. Okay. But from inside to outside, follow me here. This is the first layer, okay? That's actually having pores, and you can see it here. They call them fenestrations. And where we got that term, guys? I'm sure you got that term, fenestration, fenestrated what? Capillaries. Yeah, we talked about that type, and I mentioned those are for filtration. Yeah. So now we have those pores, okay, and those designed not to allow red blood cells to pass, even white blood cells to pass. So their diameter is smaller than the diameter of red blood cells and white blood cells. That's why we don't see what? Red blood cells, white blood cells in your urine. Yeah. Correct? Because if I see it, you have infection. You have hematuria, for example. And what is pus in urine?
Infection.
What's the term? Instead of hematuria? Pyuria. Pyuria means pus in urine. Hematuria means what? Blood in urine. Those not gonna happen unless you have infection. In infection, what happened to the pores? They widen. You have inflammatory process going on, disturbing the diameter of the filtration slit or pores, and then red blood cells can slip through. All right? Because I want you to understand, when I see blood in urine, what's going on here? What makes that those red blood cells passing through? Because of the inflammatory process. Yes.
What about some medication like pyridium that?
Yeah, it's stained. Yeah, even all of you know that if you have urinary tract infection, you get that over the counter, which can stain the urine. Anyone noted? Yeah. So this actually can treat the urinary tract infection. I'm not going to say treat, but at least kind of like put a Band-Aid until you see a doctor, you can grab it over the counter and the color can pass through it. But dye particles is not like red blood cell because it's gonna dissolve, you see? That's why the color of urine will be changed, okay? But remember, red blood cells cannot go through it unless you have infection, that's something else. Now we have another layer, you can see it in blue color, I like blue color here, you see it? That's gonna be the basal lamina of the glomerulus. Why we need this layer? This prevent large molecular weight proteins from passing through. So that's the first layer. We call it the basal lamina of the glomerulus. Then you can see a slit membrane. See that? Kind of like a pinkish color. Yeah, that's actually a slit membrane between the pedicels. You can see it here and here. All the pinkish color. This actually prevent the medium-sized protein, molecular weight protein from passing. Now, if I check your urine, can I find trace amount of protein? We send your urine for analysis to the lab, and the results came in trace of protein. It can happen. I'm not gonna make a big deal of it. Because sometimes maybe you exercise, you went to the lab and gave them like a urinary cup and then filled it, but immediately after exercise. Sometimes we find trace amounts of protein that can happen because of the exercise that you've done. Suppose you're pregnant. Pregnancy can alter everything here because remember, when you're pregnant, you increase your blood volume, okay? And also there is changes that can happen to those layers. So in pregnancy, if I see also trace amount of proteins, it's fine. That's normal because of the changes with the hormones that happen in your body. But too much protein, now it is called proteinuria. Here I'm gonna put question mark. If I see heavy protein in your urine, that means there is infection, there is nephritis, or they call it glomerulonephritis. It can be acute or chronic. So in this case, they have to follow up with you and do kidney function tests. They can do all the bun and creatinine, the one we talked about, blood urea and nitrogen beside the creatinine, and definitely those going to be increased in your blood, in the plasma, all right? So those layers, as you see, layer by layer, they're designed to trap large molecular weight protein and medium-sized protein. Yeah. Low molecular weight, they can slip, but not in high amount. We call them trace amount of protein, it's fine. Even the doctor will not call you back to follow up with you. Okay? So that's about, hopefully if today we can, or I said Thursday, dissection of kidney. Today, I said, today, okay. We can do the urine. Because kidney, you can finish it in 10-15 minutes maximum. All of you can see all the structures. And then we can do the urine, your own urine. So we come after break. We're gonna give you urine cup, instruct you what to do, and we have a dipstick method that can test 10 things in your urine. Maybe I can lecture on those before you start doing it. Just you should be aware what you're checking for, okay? So I'll give you a hint, because it's 10 SG, they call it urine dipstick method. Very easy, you just dip it in the urine and read it, compare it with the bottle. So the bottle has the colors, and you can see if you have sugar. Hopefully none of you will have them unless you're diabetic or something else. No bilirubin, we don't want to see bilirubin, as I said before. Infection, I would recommend midstream catch. Midstream catch always is the clearest urine that you can get. So what midstream? Pee, hold it, then pee in the cup. It has some kind of, and if we have a toilet, that's the one to clean the orifice, that would be good. So I'm gonna ask them in order to get a clean catch. All right, so we'll see what they have. So today you're gonna dissect the kidney and we're gonna do urine analysis. All right. So any question on that, guys? The anatomy, deep anatomy, how the filtration start from the inside to the outside. So when it passes through those slits, where it's gonna end? Always capsule, exactly. It's gonna end up here. Because you see how they cut section here to show you all these, then the urine will end up here and continue. Now, here is the same thing repeated. It's just function of each part. For example, the proximal is the major one that can reabsorb the sodium and chloride. 60%, that's a huge amount, huge percentage of sodium and chloride will be reabsorbed where? In the proximal. See, that's the proximal. See how, well, although it's short, but look at its function. So we're gonna get as much sodium back to your blood. And look at the spider web, ready to take everything back. You wanna ask me why this happened? Because this is very active. This is super active. I just wanna show you glomerular filtration rate. We were able to measure it. They gave like an inulin substance, inert substance, you take it. The good thing you don't absorb it, but it just goes to the urine. You don't break it down, it's inert substance. So when you take it, it comes all in urine. So it helped them measuring what? The glomerular filtration rate. And look how much it is. You'll be amazed because I want to show you the super activity here. It's about 110 cc, which is milli per minute. Okay. Let's calculate this in 24 hours. First, I want to do this per hour, correct?
Yes.
Yeah. So you multiply. No, that's not a good one. Let's try the blue here. So multiply by 60, correct? That's the first thing. So that's per hour?
Yes.
Hour is 60 minutes.
Yes.
Yeah. I multiply by 60, then by 24. You have your calculator in your iPhone? Calculate.
158,400 cc's.
Let's say 1,000. Okay. Anna, all right?
60 liters.
CC. Okay.
See how it works.
Now, see, convert CC into liter. What should I do? Divide by 1,000. A little bit of math, guys. We're not complicating it.
158 liters.
So divide by 1,000, correct? Those will be crossed, and 158 liter now. We want to convert liter into gallons. What we should do here?
Liters.
A gallon, how many liter, guys?
It's like
3.8. So from liter, from small to big, always divide, correct? That's the rule in math. We learned it in elementary, if you remember. Yeah. So, remember that?
Yes.
Yeah, from small to big, divide. From big to small, what?
Multiply.
Multiply. That's how they taught us. So now we're gonna divide this over 3.8. What is the answer? How many gallons?
Roughly 41 and a half.
Very good. And I had my students before they measured it, they were, so that's with the gallon now. All right. Now, do you have urine 41 gallon a day? Because that's 24 hours, correct?
Insane.
Yeah. So what do we need here? We need a spider web that you see it around your tubules to suck back as much as we can, especially water. Yes, we have the sodium, the chloride, that depends on your body need. If you eat too much pickles that day, do you need activity of sodium to be sucked back to your capillaries here? No, because rich in sodium. So you want to dump it in the urine in this case. So instead of tubular reabsorption, you're going to have more tubular secretion of sodium. That's what we call it homeostasis, depending what you're eating every day. Yours is different than mine. Maybe at that day you ate too much salt, okay? Or someone is avoiding salt on that day. So he needs more reabsorption of sodium. Make sense, guys? And that's through the hormones as you learn. Aldosterone, remember we talked about it, how it helps in reabsorption and things like that. So I want you to understand that if I calculate the filtration here in all millions of glomeruli or renal corpuscles, I'm gonna end up having 41 gallons because they were able to know GFR per minute. We did a physiological test by giving inulin, inert substance called inulin. And physiologists were able to know the filtration per minute. Now I calculated per what? 24 hours per day. And see how many gallons. But you don't have urine 41 gallons per day. How much we have per day? 1 to 1.5. Around there. 1 to 1.5 liters. That's what you have per day. If I ask you why, it's all about tubular reabsorption. It's a very active process here, taking the water back and taking electrolytes as much as your body needs. Makes sense? Oh, okay. So let's go to descending. We have descending, ascending. We're done with this one. We said sodium chloride, 60% an average. And we're now gonna go to this signal, only the descending, okay? Now we have a lot of capillaries here. Look at the spider web. This is a very active. This is what we call it the nephron loop. Nephron loop is the same as loop of Henle. Whatever you want to call it is correct. This actually is the most, I would say, active because of the crowdedness of the capillaries surrounding it. And because of that crowdedness, they call it vasa recta. Vasa recta. Right? That crowdedness is unique surrounding the loop of Henle or nephron loop. This is the site where in the future they're gonna teach you in pharmacology something called Lasix, which is a diuretic. And this actually, if you go and Google it, it works on nephron loop. So that's the one can like decrease the reabsorption of water from nephron loop and make you what? Pee a lot. We call it the water pill. Yeah, water pill. So Lasix, Biomix, you know, there's a group of that. You're gonna learn them in pharmacology. They exactly when they talk about how we classify them, they call them what? Loop diuretics. Lasix, Biomix, we call them loop diuretics. So why they call them loop? Exactly, loop of Henle. Loop of Henle. So exactly they work here. And imagine if you don't know anatomy, you're not gonna understand pharmacology even. Because look at the link. And that's why I said at the beginning, if you remember, I said the A and P is your basics. If you don't perform good on the A and P, you're gonna suffer. You're gonna go by your own and say, oh, I didn't learn loop of Henle. What's loop of Henle? I didn't even heard about it in A and P. Now you're gonna have a problem understanding loop diuretics. You see, it's connected. It's all connected. So put effort in A and B. You're gonna excel in everything. I guarantee it, guys. You're gonna excel in pharmacology because you're gonna memorize drugs and classification, where they work. And you're gonna excel as well in pathophysiology, the mechanism of disease in your body. If I don't know physiology, I'm not gonna understand pathophysiology. So it's all connected. Ascending portion, you can see it. That's also aided in pumping more of the sodium and chloride. So it's kind of like assisting the job of what? Proximal. Yeah, the first job, chloride. The distal is very important. It has kind of like a different function. The distal is rich in two types of cells, intercalated and principal, and I talked about them, and I said, be aware that those are important in theory. Principal cells under the effect of aldosterone, and aldosterone affect principal cells by helping reabsorb the sodium, and not a lot, but because we just talked about sodium in proximal, we talked about sodium also in the ascending, if you remember, we mentioned the ascending also is important, but they said 15%. The good thing, we don't need the hormones to function unless your body in kind of like distress condition. So the 15%, the hormone would be helpful working on those principal cells. Under normal condition, you rely on proximal and you rely on what? Ascending. So that's why 85% of reabsorption occurs without the hormones. 15% again would be relied on the hormones, and that will be needed if your body is in distress. And that's by functioning the aldosterone on which cells? Principal cells.
What was the other cell?
Intercalated. Intercalated cells. Where we got the term intercalated? Where?
The skeletal, or no, the cardiac.
The cardiac. The gap junctions, remember I said intercalated discs?
Yes.
Yeah. Here now you learn intercalated cells.
What?
Same spelling. Intercalated, same spelling. With a C. Okay? So those, the one in the distal as well. And those are the one that regulate, I mentioned it last time in the other room, H ions, and HCO3, the bicarbonate ions, the cation and the anion. You see, those controlled by those cells, the intercalated cells. So if you have acidosis, and remember I explained to you acidosis, and I said in the TEAS exam, they're gonna ask you those questions. The neutral is 7, and if I go to the left, that means acidosis. And if I go to the right, that means alkalosis. Okay? I explained to you this. So if I have excess of H ions, where that's gonna be, left or right?
Left.
Mm-hmm. What happened now to the bicarbonate? Drop. Opposite would be here, correct? And don't forget I added to you here increase PCO2. pressure of CO2 will be always on the left. So if you want to explain this, why when we increase PCO2 end up with acidosis? Because I don't want you just, memorize it. No. What CO2 likes to combine in your plasma with? What's the majority of your plasma? Water. 92%. So look here, simple reaction. What's the answer? When CO2 combines with the water, what it makes? An acid, carbonic acid. It's a weak acid. It's in your blood. Carbonic acid is a weak acid. It's not like the acid in your stomach. It's a weak acid. So H2CO3, carbonic acid. So if I increase pressure of CO2, definitely I'm making more of that acid. It's acidosis. It's to the left. Do not memorize. And we have a chapter acid-base balance. So it is based on your understanding here. I'm gonna repeat it one more time. Now the opposite will be where? To the right. H ions drop. What happened to bicarbonate? Goes up.
Increase.
Mm-hmm. Okay. And of course the PCO2 would be dropped in this case, and so on. All right? So make sure to know and understand it, not just memorizing it. Any question on principle? Yeah?
So we said that the principal cells and the intercalated cells were in the DCT, but I thought they were also
In the collecting duct as well. There are some in the collecting duct, yes.
Oh.
Yeah, you can add it. There is some in the collecting duct. And as I said, those will help in 15%, because most the principal cells can function under the effect of aldosterone in case your body goes into distress condition. All right? Distress condition. For example, if you're running in a hot day and you're sweating, we need more reabsorption here. Because in the sweat, you're losing also sodium. Yeah, you need electrolytes to hydrate. So I expect now your aldosterone working on principal cell, because I said 15% in stressful condition. Okay. But right now, you're not in distress condition. So enough, the 85% will be more than enough to reabsorb sodium through what? Proximal and ascending. Now I want you also, I know the diagram is not showing you, unless you guys can see it here. Can you see this is thinner than this?
Yes.
Thin wall and thick wall. Maybe if you, not really. Maybe I can see another picture, because here I think the capillary is masking the view. But if you kind of like, maybe if you have your computer with you, look at this, how thin, and look, this start to be thicker. Thin wall and thick wall. Why? If I ask you which one it can reabsorb more water? Because I said this is the loop of Henle, this is the nephron loop, having two-sided descending and ascending. We found the descending having thinner wall, the ascending having thicker wall. The question is, which one can reabsorb water more?
Descending.
Very good, descending, thin wall. The ascending having thicker wall. Water goes passive, so it doesn't need even energy. So if I have a thin wall, that means the descending will reabsorb more water. Now, the other question here, what do you expect the filtrate within the descending loop of Henle, which is the specific gravity? Osmolality, is it increase or decrease?
No water, impermeable.
So what's the answer? Increase or decrease in specific gravity? Who can answer this? Descending. I'm talking about the descending. Remember, water leaves easily.
What was the question?
The question again. Okay. The descending, having thin wall, correct? Water leaves easily and goes to those vasa recta, the capillaries, correct? My question is, what do you expect the specific gravity of the filtrate inside the descending loop of Henle?
What does specific gravity mean?
Osmolality.
Should be
Decrease.
high.
Because it's in.
Goes up.
Yeah, it's.
You lost the water from it, the concentration goes up,
Oh, so this.
correct? You lose water from it. Water always dilute.
So
So the specific gravity here start to increase. The more I go to the bottom, the more I have concentration of the filtrate, which is inside the loop of Henle, which is the descending loop. When I go up now, what do you expect? The wall is thicker, water having hard time leaving. So what do you expect the specific gravity?
lower.
Lower, because there is no much water is leaving, is sitting inside because of thick wall. Make sense? And I want to show you this. We have a diagram. I show you the specific gravity, and I want to prove to you that whenever you go down, it increase in the descending and decrease in the ascending. But wait until we get to that. Yes.
So our descending is reabsorbing water and our ascending is keeping it? When that
Yes, because of
balances
thick
out,
wall, water having hard time to leave.
What's the function of that if it's, they're
That's
both
why
just counteracting?
it's just we found the descending is concentrating segment of the filtrate because water leaves easily. It's just a changing that happen from descending to ascending when it travels within it.
Oh,
That's what we found. Yeah, it's a changing in osmolality, and I explained to you why. It's all about thin wall, thick wall. That's what plays a big role in that. All right? So if I bring you a question, which of the following is the concentrating segment of loop of Henle?
The ascending.
The what?
Ascending.
Concentrating segment.
Oh, no, descending.
Descending because water leaves. Yeah, water leaves easily. We said. Yeah, descending. Yeah, so we consider it the concentrating segment of loop of Henle, which is the descending. We're done with that. Apparatus. Yeah, the juxtaglomerular cells. What do they produce? Okay, and what renin is important for? Blood pressure regulation, exactly. And if they ask you, what's the proof? Tell them if someone having bad kidneys, he's gonna have problem with his blood pressure. Why? He's not producing renin effectively as healthy kidneys. So he's gonna having renal hypertension. That's what we call it, renal hypertension. It's classified. So your kidneys goes bad, what's gonna happen? You can develop hypertension. But this is not a familial, this is a secondary hypertension. You develop diabetes, then you have hypertension. This is secondary. You have hypertension out of nowhere, and the doctor tell you, oh, familial hypertension. Yeah. Because we don't know why. You don't have diabetes, your kidneys are okay, but you have hypertension. So you call it primary or familial. Okay. Any question on juxtaglomerular cells? What they do? Here is the macula densa again. So the good thing, other thing I want to talk about the macula densa, guys. We found that inhibit the release of nitric oxide from the lining, which is good, because nitric oxide help in what? Dilating. What's the proof that nitric oxide help in dilation of the wall of the capillary. Clinical. Clinical. In heart attack, what you put under the tongue? Nitroglycerin. Isodil, they call it. Isodil tablet. Sublingual tablets. Why? Why nitroglycerin under the tongue? Because that's the one dilate the coronaries. And if there is a clot, at least it can move and stop that obstruction. Because if there is obstruction, you're going to have ischemia. And if there is ischemia, you're going to have myocardial infarction. Death of the tissue. But giving Isordil under the tongue, which is nitroglycerin, which change into nitric oxide, dilate the capillary wall, and open the coronaries. Even not just targeting coronaries, by the way. What's the most thing you should pay attention as a nurse when you put Isordil in the under the tongue for a patient? Yes.
So every 5 minutes they can take it and you gotta monitor.
But before that, before
You gotta reassess them to
Flat.
flat, supine, laying down, because I said it can dilate all blood vessels and the blood pressure drops. Imagine I having him stand up and I put one after one. What's gonna happen? He can collapse. He can faint.
For how long are they supposed to be laying?
Depending on the pain. Like he said, after 5 minutes, put another tablets if it doesn't work. And as long as they're flat, don't worry. They're not gonna faint. Yeah. So this is something I want you to understand, that also the macula densa here inhibit the release of what? Of nitric oxide. Because we know nitric oxide dilate, and we don't want dilation here. We want tone, correct? Tone in the afferent wall, afferent arteriolar wall. And that's helpful to keep the pressure. Because why I want to keep the pressure here? Because the pressure here reflected in the glomerulus. And if I have pressure in the glomerulus, I'm gonna have filtration. And the filtrate keeps moving. So that's what we found about what macula densa. It inhibits the release of what? Nitric oxide. It inhibits the release of nitric oxide, which is good. Because we don't want to dilate. But we need to dilate if someone having heart attack, correct? That's why we use it. Okay. So any question up to here? That's from another source. I brought you this also. Here is the mesangial cells. You can see them here. And we said to clean up any debris stuck in. Okay, so that's why they will be considered what as part of the immune system, like phagocytics also, mesangial cells. So you learned in the liver also phagocytics. Who remember the name? Every system, notice we mention phagocytics. In the skin, you learned it in part 1. What's the phagocytics of the skin? Langerhans, very good. What's the phagocytics in the liver? Digestive, we learned it. Kupffer cells. Now we learn mesangial cells. Every system. Blood, we know what's in the blood. Yeah. They're distributed all over your body, even in organs, as you see. Okay, so we have the mesangial cells, and those we call them the juxtaglomerular complex, which is made of macula densa, extraglomerular mesangial cells, and juxtaglomerular cells itself, which produce what? Renin. So they call them the complex. Okay? Yeah. It's good to know those. Yeah, they're in a square here. And those we call them juxtaglomerular complex, made of the three. I talked about the red blood cells, they're not gonna pass through those pores, if you remember. Why? Look, the diameter, 7 microns. So the red blood cells will not pass. No need to repeat those, because I talked about the 2 types of cells. Make sure this is important. Also slide, principal versus intercalated. Principal under the effect of aldosterone and ADH, and the intercalated cells, they just dump the H ions or retain it, or dump the bicarbonate ions or retain it, which I put them for you here. Okay, that's the function of intercalated cells. So they manage the pH. We have more nephrons in the cortex, and you saw the cortex, and you're gonna see it today when we dissect the kidney. Okay, so you're gonna see the cortex is a painted area, the peripheral area. That's the cortex. Imagine with the cortex we have 85% of the number of what? Nephrons. And we call them cortical nephrons. The name came from the cortex. So most of your nephrons are in the cortex. And they have a long lobe of Henle. It has to be. While the medulla has what? Short lobe of Henle. And create osmolarity, we talked about that. Concentration of the urine. Oh, that's what we spent time talking about. What it says here. Ascending, not the descending. Ascending has what? Thick. Correct? Thin after that, because after that it starts to thin, of course. But the majority of it is thick. So because it's thicker, it won't allow the water, and the descending is thinner, it allows more water to pass through, and that can change the concentration, of course. That's the cortical and juxtamedullary. You can see cortical has short, and juxtamedullary has what? Long. You see the juxtamedullary?
I thought the medulla had a short loop.
No, the opposite. So cortical has short and juxtamedullary has long. Okay? So the juxtamedullary has longer. You can see the diagram. You can look how long it is. That's juxtamedullary. Why they call them juxta? Where that term came from, juxta? Junction. Yeah. It's kind of like not in the cortex, not in the medulla, at the junction in between. So they use that term. Juxta is junction. But this is, of course, mostly where in the cortex. You see? Look, mostly in the cortex. But this at the border. At the border. So they use the term juxtamedullary. Kind of like a closer to the medulla. Yeah. So short loop of Henle for cortex, and longer loop of Henle in the juxtamedullary. And now we want to understand the pressure players, some physiology here. It's not kind of like hard, I'm not seeing it hard, but I want you to understand that there are players in this, which is the pressure in the capillaries, and I can see it here. That's the pressure of the capillaries, see? Without the pressure in the capillaries, which is reflected from your pressure, your blood pressure, imagine the heart is beating, you have 120/80, it goes through arterioles, it goes through the capillaries, correct? So it ends up here in the glomerulus, because glomerulus is capillaries. That's what the glomerulus, the head of the snake, remember? It's all having the glomerulus and the what? Bowman's capsule. So now look at the capillaries. Without the pressure reflected from arterioles, which of course reflected from arteries. You remember we have renal artery going in, that's bring a huge pressure to the kidneys, then divided into arterioles, pressure start to drop a little by little, but again it dropped more and more, but still maintained. There is pressure here. And that pressure is important because if this pressure is not higher than the pressure within the Bowman's capsule, you're not going to have filtrate. And this happens when you have shock. In shock situation, look, huge drop of the pressure. If the main pressure drops, maybe 70, 60 over 50, let's say in shock, severe shock. Do you expect that the pressure here will be able to push everything to Bowman's capsule? No way. That's why we have oliguria. Less amount of urine will be produced in this case. But under normal condition, we know that the pressure here maintained and it will be exceeding the pressure where in the Bowman's capsule. And that's how the filtration occurs. The green color, you can see it here. So the filtration from the blood, plasma into nephron, you can see it here. Then we have the reabsorption, you can see this arrow, and secretion. So if I balance it between reabsorption and secretion, that's going to be the amount of urine will be coming here, correct? So if you minus this from this, you're going to have the amount of urine that produce every day. Because you reabsorb and you what? Excrete or secrete. So the balance between secretion and reabsorption, which I'm going to abbreviate it as TR, tubular reabsorption, and TS. That's what decide your amount of urine. Make sense? Yeah. Everyone's body is different based on what you're consuming every day. Are you exercising? You see, it's all factors that affect the secretion and the reabsorption. So the arrow goes back to the blood, put on number 2 here, TR. And they put it for you here, they put it for you. Tubular reabsorption, TR. And when it goes back, if I don't need it, like drinking too much water during the day, which one you're gonna have more? Secretion, exactly. So everything here I want to get rid of. So you get rid of that and it goes into your urine. Okay. You didn't drink water for the whole day. You fast for the whole day, okay? Fasting for the whole day. What happened to the water? More TS or TR? TR.
More TI, right?
TR, yes. More TR, you want to reabsorb back to your blood. So the TRTS is depending on your body condition. And we always have it in homeostasis. TRTS. Look at the arrows and understand what that means. Okay, another question. You ate too much pickles during the day. We know pickles has huge amount of sodium. Now, which one gonna be more for sodium? TR or TS?
Yes.
TS, you want to get rid of, correct? Why you want to reabsorb? You have too much in your blood. Why you want to reabsorb? So TS will be more than TR. Is it clear for TS, TR? And that's how we decide homeostasis. Yeah. Everyone's body is different based on consumption, exercise, all those factors we call. Okay, so.
So if you exercise, then your body would be wanting to reabsorb it, right? Because you pushed a lot of sweating and
Yes.
got a lot of sodium out.
Exactly, but all of this happened in the kidneys.
Yeah.
They decide how much I can get back and how much I can get rid of through the urine until it's balanced. Imagine homeostasis. This is a good example on homeostasis. Many things we talked about homeostasis. When we talked about hormones, we brought examples. When we talked about, remember, thyroxine, we talked about PTH. It's all have to have a normal range all the time. Even your insulin, glucagon, homeostasis. So now you learned it here in the kidney. Oh, here is the calculation that we did. It came back, guys, and I think one of you gave me the 158. Remember, you gave me the 158. I remember, the liter, here. What it says here. In one day, 150 to 180. Of course, our body is different, but we have the average. We calculated 158 liter of water passed out into glomerular capsule, which is correct. And we did the calculation for that. We did it for all the millions of glomeruli. And without reabsorption, guys, we're gonna be dehydrated in less than a second, I would say. If you don't have reabsorption and get that water back, and we talked about the descending, how it has thin wall, passage of that water will be easier back, which is TR. The TR of water will be more for descending because it has thin wall. And what happened to the concentration of the filtrate inside the descending? Goes up, sucks the water from it. Concentration, which we call it osmolality. You call it specific gravity, whatever you want to call it, it goes up. Today you're going to check also specific gravity of your urine. You drink too much water, you're going to have water urine. So specific gravity will be low. How about diabetes insipidus? What do you expect specific gravity?
Low.
Very low. Like what? Exactly. Why? Because they lack ADH. We don't have enough ADH, antidiuretic hormone. Correct? Which sucks the water back. So water urine, we call it. So we did that. Okay, we even converted into gallons, if you like. But that's not going to happen because of reabsorption. Glomerular filtration rate, GFR, we talked about it. Homeostasis requires kidneys, we just talked about it and how we balance it. Too high substances pass too quickly and are not reabsorbed. Too low, nearly all reabsorbed, and some waste products. Yeah, it depends, but you are in homeostasis all the time. This is to show you the pressure in different segments. Here is the pressure in the arteriole, okay? And we will be going all the way to the inside. And we have a pressure resisting it, which is within the Bowman's capsule. And don't forget also this blood having albumin, correct? Albumin everywhere. I can say albumin only in your arteries or in the arteriole or in the venule. We know albumin all over your circulation. We talked about it. So this is going to be to the inside, correct? That's within here we have blood colloid oncotic pressure or osmotic pressure. We talked about this before, if you remember, when we talked about, who remember?
Filtration of tissue.
Reabsorption, filtration, reabsorption. The two-sided of the capillaries, the arteriolar and the venular. We talked about it. But at least now you remember that we have albumin in the capillary blood here, and that's going to be to the inside because try to keep everything within the capillary wall. Okay? So to the inside, we have 30. And what's also to the inside that can like resist the filtration and try to filter everything here, but there is a pressure here, correct? You can't ignore a pressure within a capsule, within Bowman's capsule. So that's kind of like resisting the filtration, correct? So it works side by side with what? With the oncotic. Because I said the oncotic within the capillaries is to the inside. So you have two pressures here enforcing each other's. Makes sense, guys? Albumin keep the blood within the capillary wall, and this is called oncotic plasma pressure. We agreed on that? Okay. What also worked in the same direction is the pressure within the Bowman's capsule. Because you're trying to filter outside, but there is resistance here, there is a pressure. And that resistance, it works side by side, the same direction with the albumin. So I can add them together because they enforce each other. So now we're gonna add 30, which is blood colloid, plus what? 15. Make sense, guys? Now, we're gonna see now the pressure inside the capillaries. If it exceeds those two, that means filtration occurs. So let's see the pressure inside. What is the pressure inside? What it says here.
55.
Okay, 55 minus the 2. What's the answer? Let's say 30 and 15.
10.
What's the answer? 10. 10 to where now?
10 down the.
Exactly, to the Bowman's capsule. And that's how filtration occurs. And if you have shock and that pressure drops, it missed everything. You lost that 10. You lost that 10, guys. So now you're not gonna have urine. Because I want you to understand why in shock they don't have urine. That's how you explain it. In physiology, now you understood it. It's all about the pressures, to in or to out. Which one gonna win? That's what you're gonna decide. If the out gonna win because it's 55, you're gonna have filtration. If the out is not 55 due to shock, due to severe drop in blood pressure, you are not gonna have filtration, period. So we're relating physiology to clinical life example. Because I like to relate things because that's what you're gonna face in the future. You know, you're gonna work in the ER and you see someone having a drop in his blood pressure, the most worry you're gonna have in your mind is urine. So I want you to link this. He's not gonna have urine. Catheterize him as soon as possible. Because if I don't catheterize him, the toxins build up. Renal function test will deteriorate. Creatinine will go up. I can lose him. BUN and creatinine will go up. If you don't do that, we have to help him. Okay, yes?
How would a catheter change this pressure?
Oh,
If
because-
we're not producing urine, it's not getting to the
Very
bladder.
good, because you're gonna get fluids.
Oh.
Giving fluids and you're not getting out what's retained, it defeats the purpose. I'm not saying we're not gonna do something else. You are rehydrating that person. You're gonna give fluids. You're gonna give saline. You're gonna give proteins if he needs it. You know, normal saline is fine, as well as adjusting the pressure. Because we have to give tonics, we call them. We have to push the pressure up for him. Okay? So all of those will be given beside the catheterization and we can save lives. We understood now the concept? Okay, yes? Okay. GFR, I gave you, and we calculate per day, but we're not gonna have this per day. It's gonna be dehydrated within less than a second. And why we don't have this per day? Will help us here. TR, tubular reabsorption. You suck everything back to vasa recta, to all capillaries surrounding the tubules. I showed you the spider web in one nephron. I showed you a spider web in one nephron. Imagine this for millions of nephrons. How much you're gonna get back. This is just example on one nephron, guys. The diagram that we have. But imagine it in all millions. Yes, you're gonna reabsorb everything. You'll be able to get rid of that 41 gallon. Okay? So average, as we said, 110, 120, 115, it doesn't matter. Males, females. Why males, they have more? Size. Kidney size, of course. Male have more kidney size. An average. Yeah. We talked about the hormones in neural, sympathetic and para, that one I don't want to go over it. And the myogenic mechanism, as we said, smooth muscles in the afferent. We have smooth muscle also in the afferent. And we talked about the nitric oxide, also is very important here. Inhibit the nitric oxide, so it keeps the tone in the wall of the blood vessel, the macula densa, as we mentioned. All of those. Here they put it for you one more time, macula densa inhibit. Yeah, we talked about that. So all of those are important. So two factors: smooth muscle in the wall of arteriole, macula densa inhibit what? The release of nitric oxide. That's a complete answer. How we keep the tone. Because without that tone, you lose what? Pressure. We don't want to lose that pressure. We don't want to lose 55. We don't want to lose 55 because if you lose the 55 millimeter mercury, you're not going to have urine. This is the autoregulation, the one we just talked about with the renin, juxtaglomerular apparatus we talked about. It's just a repetition. And when it becomes stable and the GFR is controlled with 110, everything will be stabilized. As long as you drink more water, you have to secrete it. TS will be more. You don't want to retain water. Water is toxic if it's retained in your body. We call it water intoxication. We found it sometimes in OCD. Yeah, some people like OCD, they're scared of kidney stones, they keep just drinking water. And they're not exercising. That's bad, because you're gonna lower your sodium, you're gonna have hyponatremia. Hyponatremia can lead to hyperkalemia. Hyperkalemia can lead to arrhythmia. It's toxic to your body. Just to show you a simple water drink intoxication. Kidneys are richly supplied by sympathetic fibers. We talked about this and what the sympathetic is doing. Exercise, we talked about it. Constricted, correct? How about in hemorrhage? Let's say you have hemorrhage. The good thing, your body reacts by producing what? Renin. So if someone is hemorrhaging and you want to do experiment and take his blood, send it to the lab, you're going to find high amount of renin. Yeah. You're doing research, for example. You're in the hospital, they assign you for research on renin. And you found, of course, the doctors working on a bleeding. And they took a sample from that blood. And you send it for renin. Renin will be high in the blood for that patient. All right? So we know why. Because renin need here to what? To constrict the blood vessels, to minimize the bleeding. And you know how it works. Angiotensinogen into angiotensin 1. And angiotensin 1 into 2 by ACE. See? It's a long process here. So we need to know that renin will be high, and here is angiotensin 2. How angiotensin 2 is formed? From 1. What's the enzyme? ACE, angiotensin converting enzyme. Don't forget, guys, write them on the side here, since it's not written, okay? Put angiotensinogen, all right? From where? Who produce angiotensinogen? Liver and lungs. So put here liver lungs, all right? This would be converted into angiotensin 1, correct? Via what? Renin. From where? Kidneys. Where exactly from kidneys? JGCs. JGCs. I'm connecting the dots now. Juxtaglomerular cell. Now, 1 into 2. Why? Because this is not a powerful vasoconstrictor. We want to convert it into powerful. So we need help with another enzyme called, the one I mentioned a while ago, ACE. We're reviewing from the part that you did before midterm. And that's going to make it angiotensin 2. All right? Make sure, write it in this slide as come like additional for you just to remember how it works. Atrial natriuretic peptide, any stretch in the cardiac atrium. So any stretch in the cardiac atrium. We know that stretch can happen because you're retaining more salt. Okay? And in this case, sodium absorbs water, you increase your blood volume, stretching your atria, heart responds by producing what? ANP from the right atrium, and then it will actually get rid of what? Sodium. Look at the name. Atrial, natriuretic. What's natri we said? Sodium, uretic in the urine. So it's expel it in the urine, it increases the secretion of sodium in the urine. Peptide with the P. Yeah. Because hormone is a protein. Peptide is protein. That's the hormone released from your heart in response to increased sodium in your system. Because sodium increases blood volume. When you increase blood volume, you stretch the atrium. I'm explaining to you stretching. Because when you increase blood volume, you stretch the atrium more. And how we increase blood volume? By increasing sodium. Sodium sucks the water with it. And when you increase blood volume, you increase blood pressure, correct? So what do you expect renin here? Do you need it? No, because renin, we know what it does. It constricts the blood vessels. So you have less renin in this case. This is physiology to tell me which one increase, which one decrease. Relate things to each other. Okay. Much of the filtrate reabsorbed, we talked about it. Secretion versus reabsorption. Managing of the pH through the intercalated cells, we just talked about it. And of course, any toxins we want to get rid of. Here is the proof for what we said. Okay. Here is the water, okay, passively of course. Total amount about 3 liters, including, you know, all the things that you have. Amount in 100 liter of filtrate per day, which is 180 liter. That's the one we just calculated. Remember glomerular filtration rate in the whole day, when we multiply by 60, multiply by 24, then we got it in liter. Okay, so it's about 180 depending on the size of your kidneys. Again, we said it's up to 180. Now, how much you return back into the blood out of this amount? Most of it except 1 liter urine, correct? And here's what it says. Look, amount returned into blood, how much? Mostly, most of it, except what? 1 to 2 liter, which is gonna become your urine. Without that reabsorption, guys, it's not gonna happen. Yeah. So that proves what we talked about here, if you remember, what we talked about here, that's the proof. Protein, what I said about protein, trace, remember? The beginning I said, if I see trace amount of protein, it's fine. And you know what trace means. Very little.
Yeah.
We use that term, trace. So if you look here, total amount in the plasma, 200 gram. Amount of the filtrate per day, about 2 gram. Okay. How much you return back? And why you return them back? Why they cannot slip? Who remembers?
Fenestration.
Very good. Fenestration and the basal lamina. I showed you the colors when we magnify the picture. The fenestrations taking care of large size proteins, and the basal lamina taking care of medium size molecular weight protein. Go back to that diagram to understand it. Okay? So we're preventing them from ending in Bowman's capsule. So how much you can see in urine? Maybe nil is nothing, or 0.1. Insignificant. So that's why when we see trace, we say it's fine. But Dr. Not, I'm gonna make a big deal out of that. Okay? And usually they go with the pluses. You see, when you get your urine analysis, they put either plus or negative if it's none, or they put 2 pluses for protein, we're talking about the protein, or 3, huge amount. Here and here, a doctor may call you back and do what kidney function test. Yeah. But if it's insignificant, that's fine. Maybe, as I said, you exercise and stopped by the lab. You see, it could happen sometimes. So trace is fine. Okay. Glucose. Do I see glucose in the urine? I said it before, nil.
You shouldn't.
And we said today, if you're non-diabetic, you shouldn't see sugar in the urine when you do the strip test. All right? So look here at the glucose. Total amount in the plasma, about 3 grams. Amount of filtrate per day, about 162. So you filtrate 162 gram of sugar in Bowman's capsule, correct? But you absorb it all. So we're gonna suck it back, tubular reabsorption, to the spider web of capillaries, back to our blood. All of it. And here is the proof. What's reabsorbed? All of it, correct? What's remaining in urine? 0. Not even a fraction. So if you see any change in color, repeat the test. I can give you another strip. And we're gonna make sure, guys, you know, I don't guarantee that strips used correctly. Because if you leave the bottle open, those are chemicals impregnated on the strip. Moisture can affect them, correct? Unless it's a new, we opened it, yeah. But at least you shouldn't see that if they used it properly. Because we shouldn't leave it open. Suppose they did the test and left it for hours, exposed to moisture. It will affect the test even, all right? So I wanna make sure of that. And also expiration date, written on the bottle is very important. Urea. Okay. First of all, do we have urea in the urine based on what we talked about before? When I put toxins in the urine? Yes. Do we have urea in the blood? Yes. So let's see here, urea. Amount filtered 54 and went back 24, and of course about in the urine about 30, they said. Yeah. So half, I would say, 50% of urea filtered, 50% reabsorbed. 100% of sugar filtered, 100% reabsorbed. Look at the difference here. I will repeat it one more time, okay? 100% of the sugar filtered In the glomeruli, of course, 100% will be reabsorbed back into your blood. That means nil in your urine. Let's go to urea, look at the difference. 100% of the urea filtered in Bowman's capsules, of course, end up in Bowman's capsule. 50% only reabsorbed into your blood. That means 50% end up in your urine. And this is the proof. Correct? Half, about half. Makes sense now the difference between urea and sugar? No sugar in urine, urea is in urine. Yeah.
Another thing that we can see when a patient have a glucose urine, it's when it smells, and it smells like sweet.
That's a good thing. A smell, usually in severe diabetes, we call it DKA, diabetic ketoacidosis, and that smell is acetone. It's acetone smell, okay? Because there are byproducts in the urine will be released, and again, that's in severe diabetic acidosis, DKA, because of those acids that will be in the urine. We call them ketone bodies, and good that she mentioned it because we're gonna test this today, ketone in the urine. So if you have ketonuria, that's a proof that also you have diabetes. Or sometimes ketonuria can happen without diabetes. Who can give me example? Because mainly with diabetes we understand that.
Extreme starvation.
Very good. Starvation, malnutrition, because those came from the destruction of the fat. Ketone bodies come from lipolysis, and those acetoacetic acid, if you like to know what ketone bodies, AAA, acetoacetic acid, AAA, or beta hydroxybutyric acid. You don't need to know them in biochem, but those we call them ketone bodies. Those common in diabetic ketoacidosis. Now, for your urine today, I don't want to see ketone bodies. Remember, we're going to test 10 things today in the urine. And you learned some of them today. The protein, you learned it today. Red blood cells, you learned it today. White blood cells, you learned it today. Because white blood cells indicate infection. What else we learned? Specific gravity, remember? And now you learned ketones. Look how many things just we mentioned today. I will lecture on it also, tell you all the 10 before we go to the lab. Okay? Just to make sure. So creatinine. Creatinine, I just talked about creatinine. Creatinine is a waste, correct? We don't want to keep it, flush it. Because that came as a waste of muscle contraction. Why you want to keep it? We're not going to benefit of creatinine. You benefit of creatine. You benefit of creatine. That's why they take supplements. Now, when I build up your muscles, you take creatine. That's a protein. But creatinine is a waste from creatine. You don't want to keep it. So look here, what it says. Non-reabsorbed. All of it end up where? Urine. So when you look at this table, I want you to understand it. Translate it into sentence. Make sense with the table? Any question on the table? Much of the filtrate, yeah, by both active and passive. Yeah, we have passive reabsorption, we have active reabsorption. Brought you some of, if you see a dotted line, it's passive. If you see solid line, it's active, okay? Now, the good thing about the sodium, it can be going in between the cells, kind of like a sneak in passively, but if it wants to cross the cell, look at the arrow, solid or dotted? So that's an active process. So in between, we use the term paracellular. Look, paracellular. Going through it, transcellular. Don't be scared of terminology, guys. Para means in between. Trans means what? Through. Yeah, that's why. Trans is active, paracellular is what? Passive. Yeah, that's for this one. This is just an example for you, the reabsorption. So sodium have two processes, either active or passive, depend on if it's para or trans. Any question on sodium? And of course, don't forget that we usually exchange it with the potassium. Any pumping of sodium, we can dump potassium. So potassium can go the opposite way in case you reabsorb sodium. We call it sodium potassium pump. And exactly this is what happened here because of the ATP. ATP is needed. Look, ATP becomes ADP, adenosine triphosphate, becomes adenosine diphosphate, which is 2. That means we used 1 atom of what? Phosphate. Yeah, you used 1 atom of phosphate. Now we found that primary active transport, that's the one we just talked about it, the sodium potassium pump, which is in the previous one. However, we found that we have something called secondary active transport. If it goes into the same direction, use the word sim, porter. If it goes opposite, anti. Yeah. It's just term, we use it anti-porter or sim porter. I want to give example on that because you want to understand what's that mean. Sometimes when you pump things, other substances go the other way, or sometimes they go with the same direction. Here is an example for that. Yeah, this is we talked about it. Remember when I said 85-15%? Your book says 19-10, which is kind of like an average. So if 90 and 10 is the same as 85-15. Mostly you're not functioning the aldosterone under normal condition. Right now, do you need aldosterone, guys? If I ask you this question, right now, your reabsorption of the sodium and water from the kidney tubules, from the proximal mainly, we just talked about it, 60% from proximal, and about, let's say, a little bit more from the ascending loop of it, correct? We talked about this. Do you need aldosterone to function on distal right now?
No.
No. When you need it? Oh, I'm dehydrated. If I'm working hard. If I stayed in the gym 3 hours, I'm sweating. In these conditions, yes, because your body is in stress condition, you need help from the hormones. But under normal condition, you don't need it because look here, 90% will be function all over the tubules. And then 10%, if you need it, so you function your ADH, you function your aldosterone. If you need more water, because you're sweating, you're losing water from your body, and you're not drinking, you're not compensating even. In those conditions, yes. Okay, that's why I want you to understand what's those percentage. Let's look at the syn-porter and anti-porter. If I ask a question here, is the glucose, look at the glucose, follow me here, where here is the filtrate here, and we have the cells lining the tubule, and we have the capillaries here sitting in, waiting to get everything back, whatever your body needs. Now, glucose is reabsorbed back into the capillaries. And if you remember, I talked about it. All the glucose should be reabsorbed. Nil will be in your urine. I said it. Okay. Now I see the glucose and the sodium, they're going in the same direction. And what I said, when they both go in the same direction, we use symporter. Let's look at the antiporter. Okay. We can see in the top here, you see here, I can see hydrogen is pumped into the filtrate, correct? I'm dumping it, which can become into your urine. Maybe I have acidosis in this case, and which cells is dumping those? Which cells dumping the H ions? Intercalated cells, correct? Okay, let's say you have acidosis, too much of H ions, your body gonna get rid of it. But I looked up, when I pump this, the sodium is reabsorbed at the same time. So is this anti-porter or symporter?
Antiporter.
Yeah, you see, anti-porter. It's not hard. If they go into the same direction, like the example we gave on glucose and sodium, when they are reabsorbed, we use the term symporter. If they go into the opposite direction, we use the term what? Antiporter. That's just example on that. Same thing, sodium, hydrogen. See how they go? Make sense? Notice sodium, for example, and this one. What do you think? Same direction, correct? Yeah, but they just gave example on here and here. I don't want you to be confused, but this and this are good examples for you. Yeah. Any question up to here? Yes.
So like for antiporters, they're usually for like maintaining electrical
Yeah,
gradient.
to maintain the balance of electrolytes and to maintain the balance between what? Anions and cations. That's the whole thing. It's a balancing mechanism, but they chose those terms to be assigned to it. Now, dotted line would be what? Passive. Remember? I said it at the beginning. Dotted lines, passive. Solid arrows are active. So here's the question. Chloride, potassium, calcium, magnesium, urea, all of those passively will be reabsorbed. Are they reabsorbed back to your blood? Okay, back to your blood. Paracellular or transcellular?
Both.
Both. Yeah, that's the answer. I can see it in between, and I can see it crossing. Yes. Makes sense? We're reviewing the two terms that we talked about. So both paracellular and transcellular, you can see them here. How about the water? Passively both. Exactly. Passively both. Did they mention sodium here?
No.
Why?
Actively.
Actively, as we mentioned, and we talked about symporters, and we just saw it in the previous slide. So that's imperial, yeah, it's the same. If you understood, that's the same. Another picture here. Don't worry about it, just understand the concept. I don't bring those diagrams, but understand the concept only. That's exactly what we said about sodium and chloride. Do you need to review those, or we're good? Intercalated and principal, we talked about them. And the negative feedback, we just talked about it, you know. Every time you balance your fluids in the body, you shut off, you know, the hormones. The moment you balanced your water content in your body, you shut off the ADH. You don't need it. The moment you balance sodium in your body, you don't need aldosterone. It's that simple. So this is what we call it negative feedback, and we talked about it in the endocrine system. That's the negative feedback, see it? So it's shut off. And don't forget the osmoreceptors. Without them in the hypothalamus, we're not going to be able to control the osmolality, which is the amount of sodium in your blood. Osmoreceptors are the main thing in the higher center in the brain, in the hypothalamus. We call them osmoreceptors. Those are the ones stimulated. Okay? For example, I'm gonna go back to the pickle example that we talked about. So eating too much pickles, you increase osmolality in the blood, correct? Because we know sodium will be high, osmolality will increase. The first thing gonna be stimulated is your osmoreceptors in the hypothalamus. And by the way, they communicate also with the taste buds of your tongue. We talked about cranial nerves, remember? So they communicate with the taste buds even in your tongue, and you feel dryness immediately. You say, I'm thirsty, I want to drink something. That's the first thing gonna happen. Second, it shut off which hormone? Do you need aldosterone?
No.
Why you need it? You don't need it. Do you need ADH?
Yes.
Of course, because you have too much sodium, you want to dilute it. And that's why you drink water as well. And ADH reabsorb water in the tube.
Is there a reason why there's like a correlation between pregnancy and women wanting to eat pickles during that? Is there something that is happening?
It's just the hormones, the disturbance or fluctuation. I'm not gonna call it disturbance. Fluctuations of the hormones is also one of the
I don't know
factors.
if all women crave pickles. I feel like that's just
Sometimes they crave pickles. Sometimes they crave
Ice cream.
something else. Sometimes things that they didn't crave before,
Yeah.
they start liking it. So it's all about the hormones that play a role. But again, guys, I want you to understand that we have a negative feedback going on in our body. And as I said, 99% of physiological reactions in your body controlled by negative feedback. So when your body goes to normal range, it shut off all the hormones. As long as I kept my aldosterone in normal range, my ADH in normal range, I gotta shut them off. I don't need it. So that's exactly what happened here. Whether it's intercalated cells, whether it is principal cells, and here they give example on principal because they talk about ADH, of course, it's related. Intercalated is not mentioned here for you. I don't see it because those related to the acidosis and the alkalosis. Fluid intake is highly variable, urine concentration varies, of course, it varies with ADH, and if you don't have ADH, you're gonna have watery urine, and you're gonna be classified as a disease called diabetes insipidus. And you have to take the pills, which is ADH, hormone in a pill, exactly. Doctor will prescribe it for life. You're gonna live on that pill. So that's exactly the urine concentration. High intake dilute, we know that. And low intake concentrated. Yeah. If you drink too much water, look at your urine. It'll be like water. We know that. If you dehydrate yourself, it's concentrated. It'll be amber, yellow color. So it depends on the concentration. Glomerular, same osmolality. If you like to know the filtrate osmolality, it's the same, closer to the plasma, they said. When dilute urine is formed, osmolality in the tubule. And here's the question, I want to see now. Why it increases osmolality in the descending limb? Here, look at the slide. I'm asking why.
The specific gravity.
What?
The specific gravity.
Yeah, why? Why it's increasing?
Because the water goes
Wall is what?
thin.
Thin. Wall is thin. We just talked about. I'm going asking you what you learned today. Because of descending limb, it has thin wall. Water escaped easily. So the concentration within the descending segment is what? Going up. That's what they said. And why it decreased in ascending? What's the opposite now?
Thick wall.
Thick wall. So right next to it, for you kind of like to remember. All right, so we have here, notice, I want you to look at the osmolality, okay? They checked it. It was 300, 350, 550, 750, 900 even. What did you notice about the osmolality? Increase or decrease? Why? Thin wall. So all the water escaping, going back to the, of course, peritubular capillaries, the vasa recta, that's surrounding it. That's why the osmolality. Now, look here what happened. The opposite, correct? Going up, even dropped to 150. And why here? Look at the thick wall. And even they highlight it for you for a reason. Yeah, kind of like stress on it because they want to prove to you it's a thick wall. All right? Makes sense now? Okay. So this is kind of like a variation in the osmolality that happens within the tubules. Thick, yeah, that's what we talked about. And same thing, just to show you the osmolality of the blood. I can see it here, kind of like a closer, you see. That's why they said osmolality of our urine closer to the plasma. It makes sense. Here is the blood. Here is the around, the same. In presence of ADH, collecting ducts become very permeable. That's true. Distal and collecting duct, they become very permeable to water. Mostly collecting duct, they're very important here because ADH can affect it, and now we suck the water back to your system. And that's the name antidiuretic hormone. That's how the name came from, because you suck all the water back to you. Tubular fluid becomes very concentrated, of course, because sucking the water from it, concentrating it. I can go back and show it to you. Go here, guys, notice. What happened? 1,000. Because of ADH here. So we're gonna take more and more of it until the concentrated urine that you get, which is about 1,200. Yeah. So today you're gonna do the osmolality test, you're gonna check specific gravity. We call it specific gravity of the urine. So today you're gonna do specific gravity and see. It can vary between they use 1.2, 1.5 instead of 1,200 and things. So you may see it even 1.5, it's fine, depending if you haven't peed for a long time. So we're not gonna make a big deal if it's concentrated or light urine, but that's the range. But it's a severely diluted urine, that's not good. You see, you have to have some concentration. Purely water urine is not good. You need to have some concentration to know that your tubules are functioning. So look here at the collecting duct, and this is the effect of ADH, because ADH sucks water. Oh, here it is. Look, water. So now it becomes more concentrated, and that's because of ADH that I mentioned for you. What it says. Presence of ADH, collecting ducts becomes very permeable to water, and you saw it on that. Same thing here, we talked about it. Same thing, we talked about vasa recta. I talked about vasa recta, it's concentrated capillaries surrounding loop of Henle, which is the nephrotic loop, nephron loop. Very important, nephron loop surrounding here, vasa recta surrounding this area, and here we can save time today for the lab. Here are the 10 things that you're gonna test in your urine, okay? First, albumin. Trace of protein is fine. If you have too much protein, we call it albuminuria. The albumin now slipped through the pores that we said it shouldn't let the protein pass through. We talked about that in the diagram. And that indicates infection. Albuminuria or proteinuria indicates nephritis. So we should worry about it. If you have sugar, glycosuria. So sugar should be nil in your urine. Red blood cell also shouldn't be in the urine. Hematuria, if I see it. And ketone bodies, I explain it to you, which is the AAA, acetoacetic acid and beta hydroxybutyric acid. If those are in the urine, that means you have ketone bodies in the urine. That means you have destruction of the fatty tissue or the fat in your body. That means you have active lipolysis. It could be, like you said, starvation, malnutrition, and most likely, if you're diabetic, it's diabetic ketoacidosis, which is DKA. So if you see that abbreviation, DKA, diabetic ketoacidosis. Imagine the sugar can reach, and I've seen it, 700, 800, believe me. In DKA, we've seen that level. That shouldn't be. What's the maximum after you eat? Your sugar can go up to what?
110.
No, after eating. I'm not talking about fasting.
180?
Maybe 200 even, but the insulin start working to it. That's fine.
About 80, 90.
About 180 to 200 after 2 hours is fine, they said. But if it end up in the urine, that means you're diabetic, because remember we said the kidney threshold is 180. Yeah. So the moment we eat, we function the insulin immediately from pancreas to bring it down. Imagine we've seen cases 700, 800, 900 in DKA, diabetic ketoacidosis. Definitely, I guaranteed for you, if you do ketone check, you're gonna find it in the urine. They will have ketonuria in this case, okay? So for you, 0. Remember, today when you check, I'm telling you what's normal, what's abnormal. So, no sugar, no albumin, no red blood cells, unless you have your period as a female. And sometimes it happens, I have students, if you have your period, I said it at the beginning, yes, you may see blood in the urine. It depends. Ketone bodies, ketonuria should be negative, as I said. Nitrate test should be negative, because if this is positive, usually it gives pink color with the dipstick. If you see the pink color, that means you have urinary tract infection. Okay? Yeah. But again, if you see something, it depends. Are the strips expired? Did they maintain them? I don't know. It's a lab here. Yeah.
Which one's the UTI?
UTI is the nitrate test.
Everybody's gonna leave
Yeah,
everything.
usually the nitrate, they impregnated, and if it turned pink, I remember, that's gonna be retracted. If it's light pink, I won't worry about it, but if it's dark pink, you have urinary tract infection. Urobilinogen, if it's positive, don't worry about it, but bilirubin should be what? Negative. Because we know urobilinogen will change into urobilin, we know that, and it ends up in your urine, that's normal. So don't be surprised if you see urobilinogen in urine. This is normal, but no bilirubin in the urine. Should be negative. So remember, that should be negative. This is fine, okay? This is not fine, not fine, not fine, not fine, not fine.
So the only
So-
one that's fine is the euro.
And specific gravity is fine, we said, yeah. Specific gravity, it depends. You drink too much water during your break time, or less water. You have, and I can tell specific gravity from the color of your urine. I can tell. If it's too dark, I'll tell you, you have high specific gravity, which is normal. Maybe you didn't pee for a long time, which is normal. All right? So this one, let's count them, should be 10. 1, 2, 3, 4, 5, 6, 8, 9. Did we miss one, guys?
I think it's accurate.
Which one? Specific gravity here? It's,
No, I think it's fine.
it's
Trace?
fine. But I remember it's 10, unless I forgot something. Is there a following page? I looked it up. Maybe some tests they have 9, some tests 10.
There's white blood cell there.
Oh, I see. I see. Nitrate test, which indicate infection, but we have white blood cells separate.
Yeah.
Yeah, so that's why it's 10. You're gonna see white blood cells separate, but both link to each other.
Both indicate.
Indicate infection. Exactly. That's why they're common. Yeah, so it is 10. Ureters are, you can see the ureters here. Question?
So if we're doing urinalysis after, after lunch and then.
After lunch break?
Yeah, and then lunch, you said it typically goes, it can go up to 200, and I think you said transport maximum is 180.
Yeah, but I expect your beta cells gonna quickly, yeah, you're not gonna see it in the urine. Because when you eat, it's a stimulation for beta cells. Well, it's not gonna go above that. So definitely all the sugar that filtered, guys, in the glomeruli, it should be reabsorbed, as we said, 100% reabsorbed back into your blood. So nil in the urine. We don't want to see any sugar, unless you're diabetic. That's something else. Yeah.
Just to base present.
No. So today we're gonna see, the tests and look at them. And if you doubt of anything, grab another one. Sometimes I tell my students, when you dip it, the problem, I don't think we have tubes, we have cups. So you have, unless it's full or 2/3 of it, so easier you can dip the dipstick. If not, you have to kind of like dip it, fold it a little bit. So it depends on the amount of urine, and count to 5. Like let's say 5 to 10 seconds. Take it out, and then you have a paper towel, tap with the edge of it like this to get the excess urine, because when they drip on top of each other, it alters the reagents. It's all reagents on this thing. So imagine if it's soaking and starts dripping. So it messed up with the colors. So if you do it right and tap the excess urine on a paper towel and then hold it and compare it with the bottle. Yeah. All right? If you don't want to hold the bottle, take a picture with your eye. Yeah, some students took a picture and then compare it. So here is the urine bladder. Now we have Ruby, correct? I said we have Ruby also in the bladder for increased surface area and distension. It helps, of course, distension, and you can see the Ruby. Now, we notice there is an area in the, we call it trigone, which is the 2 openings of the ureter from the back. See, ureters open in the posterior surface. Yeah, those are the opening of this and this, see? And then this is the urethral opening, because here is the urethra, correct? Yeah, urethra. So now if I connect the dots, it's a triangle, and they call it trigone. What did you notice about, is there ruby in the trigone? No, they're absent. Why? Why all the bladder having ruby except the trigone? They said it can help us act like a funnel. So when the bladder contracts, it's easier to drain the urine through a segment that doesn't have ruby. Why do you need ruby? You want to bring them where? Bring all the urine to the urethra. So when the bladder wall contract, all the urine smoothly get into the trigone, no ruby, and then dripping down to the urethra. So that's the reason we don't have ruby in the trigone. All right, so we understood what trigone and what's the benefits of it. Now, sphincter. I can see this sphincter, which you can see it extended here, surrounding, connected all the way to the bones, pelvic bone, that's pelvic. That means it's skeletal, that means it's voluntary, and this is the external. And the internal, you can see it here at the beginning of the urethra, and this actually function, it's a smooth and it's involuntary. So the autonomic nervous system is the one who controls the internal, right? This is the one that you have control of when you go to the restroom.
So the
Sometimes you can
external-
delay it, correct? You delay it, it's
external
not
is
gonna,
voluntary?
what's that?
External is voluntary.
External voluntary is because skeletal, internal is involuntary and it's smooth. Same as the anal sphincter that we talked about in digestive system. Okay, so that's all about the peritoneum. You can see it here, how it covers the superior surface of the bladder, reflected on both sides and continue. And we talked about also this. Is this male or female bladder?
Male.
Male because of? And because of? From the back, seminal vesicles. Make sure to know those also in the models. Of course, we have reproductive system coming, we're gonna talk about it. But we have two models, male and female, included on your final. So we're gonna also test you as a quiz. Is a quiz next week? Next week, correct? Yes. The quiz for male and female reproductive system. I emailed you also with the study guide, the two diagrams. Yeah. Everything, know it on the diagram, apply it to what? To the models that we have. Those are gonna be the last two models that's required. The last two models. So we have the prostate, you can see it here surrounding the prostatic urethra. And the urine, the urethra, we're gonna talk about it also. It's longer in males compared to the females. We have a part here which is surrounded by the prostate. We call it prostatic urethra because it's surrounded by prostate. And we have a membranous urethra, which is in the external urethral sphincter area. And then the penile or spongy urethra, which is the longest. Okay, so those, we're gonna talk about them also in reproductive system. In the back, you can see the ductus deferens or vas deferens and the seminal vesicle where they merge into the duct, ejaculatory duct, we call it. Both of them, they open in ejaculatory duct. You can see how they both merge in one, correct? Look at this one and this one, they merge here into the ejaculatory duct. Also wait until we get this micturition or urination, the same, voiding of urine, micturition, urination, I gave you those terms. It's all about, you know, the bladder stretched with the urine. We have stretch receptors, they fire to the spine, and then, of course, the nerves will contract the bladder. And don't think that when we contract the bladder and go to restroom and evacuate, you're not evacuating the whole contents. There is 10 cc remaining in the bladder called what? Residual urine. And this is very important because in the future when you deal with elderly, where they complain of prostate, of course, because prostate starts to enlarge. We're not talking about prostatic cancer, we're talking about enlarge, just enlarge. It's different than cancer. When it's enlarged in late 50s, it starts compressing on what? Prostatic urethra. That's why they have nocturia, you know, start waking up at night and go to the restroom, but not much urine is coming out. Then go to sleep and then wake up, but not much urine is coming out. And sometimes dysuria, they start to evacuate, urine is not coming out easily. So dysuria, nocturia, all those signs and symptoms because of the prostate. Okay, so 10 cc remaining when we evacuate normally. 10 cc residual urine. So when you deal with elderly with a prostate, if there is more residual urine, you know because of prostate squeezing on the urethra, prostatic urethra. So what they do usually, when the elderly comes in, okay, give him urinary cup, go urinate. Of course, we look at that and analyze urine, but we can do ultrasound. They do ultrasound and they can estimate how much remaining urine after he urinates. If there is more, that can confirm what? Prostatic hypertrophy. It makes sense how they do it? Yeah.
And then would you get like a loop diuretic to help or not?
No, without. Yeah,
Without.
just, ultrasound, they can estimate.
Okay.
Because the ultrasound machine can tell you
Okay,
the
but
estimation of how much urine remains.
I see, but after the hypertrophy to help urination? would
Yeah.
you-
Yeah, you can. It's just, you send them, okay? They come in the early morning, for example, send them to urinate in a cup because we want to analyze it, at the same time. And then immediately after they evacuate, we do ultrasound. And the ultrasound can tell us an idea how much urine remained in the bladder. And if it's more urine retained in the bladder, that means because of what? Prostate. And we can confirm prostate, of course, because you have history. You have history of all the signs and symptoms. Okay, male, female, you can see the long penile urethra. See, that's the longest. We call it penile or spongy. I'll talk about it also. This is vas difference. I showed you the vas difference. And it opens with the seminal vesicle from the back, remember? With one opening and end up in ejaculatory duct. That's the ejaculatory duct. Believe me, when I point on this, sometimes on final they put urethra. They think this is prostatic urethra. That's the prostatic urethra. This is the ejaculatory duct, which is kind of like oblique. You see it? Yeah, so be careful with those. Ejaculatory duct opened in the prostatic urethra, then the urine comes out, and that's how the semen comes out from the semen. Yeah, semen. We're gonna talk about it in reproductive system. Longest is penile. You see it? That's the longest, penile. Female, short urethra. Look how short it is. About, they said, 1.5, 1/4 of an inch length. So that's why UTIs are more common in females, as I mentioned before. And number one cause, it was Proteus bacteria before, but nowadays E. coli. And I told you why? Because of wiping back to the front, touching the urethra. E. coli is around the anus.
Why
So
do,
that's why wiping should be from what? Front to back. Yes, what's your?
then why do, women get like more UTIs after like sexual activity?
Oh, because of irritation, sometimes it can cause, or the male has maybe some bacteria, or the friction can bring sometimes E. coli from the bottom to the up. So it has a lot of multiple factors. But washing it immediately after, it would be helpful, a lot of factors, drinking water, urinate, function the kidneys, you see. All of this, flushing it will be helpful as well. So that's a female. We're gonna talk about reproductive. I'm not gonna talk about reproductive until we get to that, but I'm gonna just emphasize on the urine. Also, I wanna add one thing. The prostate produce in males seminal plasmin. They did research on this, guys. Prostate produce this seminal plasmin, and they found it act as natural antibiotic against E. coli. That's another factor beside the long urethra that the male has. If you like, read about this research. Type seminal plasmin produced by the prostate and its benefits. So this substance was in the secretions of the prostate. They call it seminal plasmin. Yeah. And they found it effective against E. coli. So that kind of gives another protection for males. Aging, Yeah, in the aging, we know a lot of changes start to alter the whole process. You know, filtration will decrease, the GFR, glomerular filtration rate, it's not gonna be 110, maybe drop to 90. So less amount of urine, and when more urine retained, more susceptibility to infection, UTI. So a lot of things can happen. Nephrons also function decline by 30 to 40%, micturition. And again, to keep your nephrons intact, smoking, alcohol, as well as polluted water. Those are like toxins to the nephrons. Those with stroke also, the function will be declined for kidneys. That's why we catheterize them. And anytime you have urinary retention, there is possibility of either stones or infection, cystitis. So it can happen. And we're done. I'll give you a small break and we can start.
Who's done?
11:30. It's almost.
We were
And then time is flying. Okay.